Great, thanks. Thank you to the committee for inviting me to speak today. How do I do the slides? Do I? Thanks. All right, got it. So you've already heard who I am. And despite being an attorney for, I hate to tell you, 40 years probably, as Office of General Counsel reminds me all the time, I am not an attorney for the US government. I do health policy. And I have no sources of funding to disclose. I just work for the federal government. So today I want to talk to you about the collaborative work being done around the department to address the dramatic surge in STIs that we've seen in the US over the last 5 years. I'm going to give you a little bit of background about my part of the department and my office. My office and I in particular lead development of a number of the national strategic plans for the nation. And so I want to talk to you about that and how we're coordinating all of it so that you get a sense of how this STI Federal Action Plan sits within all the other work that we're doing on the various endemics. And then I also will share with you the reason I'm here today is to talk about development of the first ever STI Federal Action Plan. And as an aside, I want to say that we're really, around the department, we're really excited about the work of this committee. I think it'll add a lot to the knowledge in the country and the conversation and the guidance about various aspects related to STIs and help lead all of us. There can never be enough out there, and it all, the work we all do just leverages each other's work and really adds to being able to make an impact. All right, so my office is within the Office of the Assistant Secretary for Health, Admiral Brett Giroir, and just to share in brief, this is Admiral Giroir's vision and our overarching themes: health for all, health by all, and health in all. And we really, in a variety of ways, and I think you'll see when I talk about the developing national strategic plans for other syndemics as well, that we really want to make sure that everybody has a fair and realistic opportunity to optimize their health and distribute things in a way that reaches everybody in all sectors and policy areas. So my office in particular has quite a wide-ranging purview. We are small but mighty. These are the topics that we cover. And I just joined this office in mid-January 2019, although I do have a career working in these different areas, trying to improve the health for vulnerable populations, both in California and nationwide. But it's been really eye-opening and a great synergy of the different areas we cover because, as you all know, STIs overlap with HIV, overlap with vaccines, blood and tissue safety and availability. There's lots of intersection with the other issues that we cover. And so we're really able to, I think, do a very good job coordinating the work that we do, both within our office and around the department and the federal government in general. Because my office plays a coordinating role. It's part of the purpose of our office, not just to help set policy, but to make sure that that policy takes into account all the different viewpoints and resources that are out there, and some of the people who have spoken to you about STIs, for instance, sit on some of our different steering committees. Dr. Cheever, who was here this morning, Dr. Deal, who spoke this morning, Dr. Bolin, are all involved so senior leadership at all parts of the department and departments outside of HHS are involved. So I'm not giving you much information on why now. You all are experts in this field and you know why now. I have been authorized to share that CDC is expected to release tomorrow its STD 2018 surveillance report. And I have no reason to believe that we're going to see any change in the trends. But be on the alert for tomorrow for the release and a lot more information. All right. So some of the other national strategic plans that we're coordinating. And again, I think one of the beauties of it being under the same office and under the same team is that we really do coordinate. We have internal to OIDP, we have weekly national strategic plan meetings where we make sure that we're all operating in the same way and that what we're, touching base to make sure that things make sense. Again, we work across the department, we work across the federal government, we get public input from stakeholders around the country. So here's two of the national strategic plans that we're coordinating. The National HIV/AIDS Strategy, which used to be coordinated by Jeff Crowley's office in his prior life, and the National Viral Hepatitis Action Plan. And both of those, the current iterations, expire in 2020, so we are currently working on the next iterations of both of them to be released in mid-2020. And because both of them were several iterations into having national strategies for these areas, they are going to be broader than the STI Federal Action Plan, which is our first foray into STIs in having a strategic plan for the whole department and federal government. So these national strategic plans will cover the array of levels of stakeholders, so not just federal, but state and local, and types of stakeholders, so not just governmental, but an array of non-governmental as well, and other sectors in addition to health. I've included the goals for the National HIV Strategy. I'm going to flip back and forth, as well as the goals for the current National Viral Hepatitis Action Plan. And one of the other strategic initiatives that my office is coordinating is ending the HIV epidemic, a plan for America. I'm sure you heard this was announced in the State of the Union address in February 2019, and the goal is to reduce new HIV infections by 90% in 10 years, 75% in 5 years. And we're doing that through identifying the highest impacted jurisdictions in phase 1, which is the first 5 years, and a number of the operating divisions around HHS are providing funding initially to those jurisdictions identified in phase 1, but with an eye towards providing all of the support to the whole country. And since I've been doing this, we frequently get asked, so what's the difference? And are you aligning them? People are very concerned that we might require one thing in one strategic plan or suggest something else in another strategic plan. So we are aligning everything. We like to think of ending the HIV epidemic as an operational initiative and the other strategic plans as roadmaps. Not that there is not a roadmap in the operational initiative as well, but these national strategic plans, including the STI Federal Action Plan, don't have any funding attached to them. They are simply, for the federal government, they are an instruction to for the federal government, what we should focus on and how our efforts can have the most impact. But for the nation, they are really roadmaps for you to take as you find helpful to your jurisdiction, to your particular stakeholder purview, whatever space you work in. It's for guidance and whatever resonates with you. It is not, none of the strategic plans are requirements for any of the rest of the country. As I said, we work on them in parallel. For instance, in developing priority populations, and I'll talk about how we use the priority populations using STI as the example in a moment, but we use the same criteria for determining priority populations and determining indicator measures for how we're going to measure progress and hold us accountable. For implementing these strategic plans, we use the same criteria and principles for all of the different national strategies. And we are going to be doing ongoing monitoring and reporting. Also, we are coordinating with Healthy People 2030. We've been working with Healthy People 2030 since the inception of the work on Healthy People 2030. In my immediate prior job, I was Deputy Director of the HHS Office of Minority Health. So, I personally have also been working on this for quite some time. And as the Healthy People 2030 document and standards and indicators goes through the clearance process, we have worked with them so that even though they're farther ahead in their process than we are, things will be caught up once our strategic plans are close to be ready to be released. So, what we're all here for. The STI Federal Action Plan, as I said, this is our first ever, so it's a little bit more limited in scope than some of the other national strategic plans, which we've had the benefit of working on for a number of iterations. We decided to focus on the 4 STIs that have the greatest impact on the health of the nation: chlamydia, gonorrhea, syphilis, and HPV. And the first iteration, we're focusing on federal partners, but we're doing it in a way that I think will resonate with everyone around the country. So we're really looking to the federal partners to implement it, but things like preventing infections, providing treatment for people, working on disparities. There will be something that I think, just like our other strategic plans, all the stakeholders and at all levels will be able to see themselves in it and find it useful. And then we're looking at a 3 to 5 year plan initially. I want to just stop for a moment. I forgot to mention when I was talking about the different national strategic plans, my office is also leading development of the next iteration of the National Vaccine Plan. And obviously there's a lot of intersection. So just like the coordination with the ones I've been mentioning, we're also coordinating with the National Vaccine Plan, and with that as well, have the leaders from around the federal government involved and doing a lot to gather stakeholder input. So we're looking to release the STI plan in 2020. We have a federal steering committee that meets monthly. It's developing visions, goals, priority populations, strategies, action steps, indicator measures. There's been incredibly robust participation. I've been very gratified by the excitement around the federal government and by the different federal agencies and departments really giving us their top experts and the amount of work that people are devoting to this. We did want to make sure that we got stakeholder input, and we had a number of listening sessions and public comment, written public comment, March through June. It wasn't a longer period because the time frame for doing this is so compressed. We don't want to let perfection be the enemy of moving forward. And so we're looking at getting this out in a very compressed time frame, and we did do a lot to really get a lot of public comment. And you'll see we had, like for our listening sessions, over 1,000 participants. So it wasn't long, but it was fairly robust. And we also have a new website, hhs.gov/STI, which will be the homepage for the STI plan. And also I want to introduce Melissa Habel, who's sitting in the back there. Melissa is the STI SME in my office, thanks to Gail Bolin on detail from CDC, Division of STD Prevention, and has played a very significant role in all of the work that I'm presenting today. So here's the list of who's participating in the steering committee. I know it's a lot of acronyms. Many of you know the acronyms. If you don't and are interested, just ask afterwards. In addition to the steering committee, we have subcommittees that do a lot of the, they do a lot of the legwork, and then they come back to the steering committee and present their work for the steering committee to discuss, ask questions, debate, and ultimately adopt the different things that will be in the plan. And in doing this, we've made clear that the charge to the subcommittees includes a lot of cross-cutting issues. So for instance, even though there's a subcommittee on disparities and coordination, we wanted to make sure that everybody considers disparities. We want to make sure that everybody considers stigma and discrimination and the social determinants of health. And one of the themes, both in this National Strategic Plan and the other ones that we're developing for the next iterations, will be integrating the approach with the different syndemics. So for instance, I expect that the STI Action Plan, as well as the National HIV Strategic Plan and National Viral Hepatitis Strategic Plan, will include what I, in my very scientific way, call one-stop shopping. There should be no wrong point of entry, no matter what the infection. And my hope is that even though we have different national strategic plans at this point, as we move towards the future, we will be able to, through more integration, integrate the infrastructure as well, make it more efficient for everyone, reach more aspects of people's health, and really be able to, in a more efficient, coordinated fashion, improve the health of people in this country. And I know there's going to be questions about, can I share some of the specifics in terms of vision, goals, priority populations? And the answer is not at this point, because for those of you who have worked with the federal government, you know everything in the government goes through a clearance process, and the STI Federal Action Plan is no exception. When it's all done, well, it won't be done. When it's drafted, it will go through a very extensive clearance process. And until the clearance process is completed, we can't really say for certain what's in the plan. But in terms of priority populations, what we're looking at is really on a nationwide basis, taking nationwide data, what the incidence of the infections, and then for certain populations where the population isn't big enough that the incidence rises to the level of priority in terms of numbers, the prevalence, so that there may be some populations where they have high prevalence but not high incidence. And again, we use the same criteria in all the national strategies that we develop. And another thing in terms of priority populations is, we're the federal government and we can only rely on nationwide data because we're doing it on a nationwide basis. But we're going to make very clear in the discussion in the STI plan and the other plans that wherever you sit, whether you're at the state level, a local level, whether your stakeholders are a particular group, you should look at the data for your particular stakeholder group or your particular purview. And it may be that what we call priority populations differ for you than what we've identified based upon the nationwide data. And I'll just give you two examples in terms of the federal government. Indian Health Service obviously has a very specific population that they serve, as does the Administration for Community Living, which serves people with disabilities and older people. I've got a couple slides on public comments, and in the interest of time, I'm not going to really talk about the public comments. I know that the slides will be shared, but again, we did do a pretty robust process, and for our listening sessions had well over 1,000 participants. In response to the request for information for written comments, we had 115 sets of comments received. And generally, the written comments are pretty extensive because they're from stakeholders who work in this space and are already very well versed and have a lot to say. So I'm also sharing with you some of the common topics in the public comments. And I just gloss overview: innovation and technology, including diagnostics, therapeutics, and vaccines, research and surveillance, provider training, including sensitivity training in STIs and sexual health basics, use of a lot of different settings for education, screening, and care, social and structural determinants of health, stigma and discrimination. Anyway, you can look more closely at the slides. And in terms of moving forward, we are, as I told you, as you can see, we are working very fast, but very hard and very carefully. And once we have all the different things in place, while the STI plan goes through the clearance process, the federal agencies are going to be working on their own agency-specific implementation plan. And the agency-specific implementation plans will also be published. I think that that will be published separately at a later time because it's just the agencies need the STI plan in order to develop their agency-specific plans, and so the timing will be staggered a little bit. But we are planning on continuing to monitor and report on progress, and so we haven't worked out the nuances of the logistics, but there will be some type of federal implementation steering committee. And here's a snapshot from our STI plan website. Here's how to reach me, and not specifically related to the STI plan, but I just want to give a plug for some of what Dr. Chesson said, that my experience, my now 9 years working in the federal government, developing the ACA, doing minority health, and now these action plans, is whatever the issue, the business case is essential. And so we in this room all agree it's the right thing to do, and it's an appalling state of affairs where we are in the nation with STIs, but showing the business case, the economic case for why in the long run, or even in the shorter run, preventing and treating is is cost effective, goes a long way to making folks take action. So I'm here to answer questions if you want. You can always reach out to me, always happy to talk, and thank you for the work you're doing.
Thank you very much. It's not a long walk, but perhaps you'll be more comfortable if you come on over to the table, and we have a couple of folks right away. So Patty and then Case.
Thank you so much for a really nice talk. My question is, so I think most of STIs are actually diagnosed in the private sector, and I was just wondering how y'all will interface with the private sector.
So the way the plan will be structured, again, the first iteration is focusing on what we, the federal government, can do. But some of the things being talked about have to do with expanding training, doing what we can do to expand points of access. And some of that is the private sector as well. But I think, again, this iteration is focusing on the federal, and I do expect the next iteration to have a broader focus.
Thank you. So there appears to be quite a bit of overlap between what you're doing in the Federal Action Plan and what we are sort of commissioned to do in our committee. So how do we avoid sort of duplication of efforts? Is that something that we should be concerned about, or?
I had the same question. What would you already told us that the business case would be something especially helpful for us to contribute to. What else might be friendly amendment?
I'm hesitating because on one hand, I can give you guidance, and I'm going to look to Gail Boland as well, CDC commissioned this study. But in part, I think the hope is really that you look at it independently and tell CDC, NACCHO, us, because we all look at the work that NASEM does, what your thoughts are. And we can learn through, to the extent that there's overlap, I think it will really solidify what we're both doing. And to the extent that you find things or recommend things that we don't address, we will take that very seriously and look at what we can do. I don't know, Gail, do you want to?
Yeah, I would say that I see them a little bit differently in that I think the federal action plan is catching up for the federal government of what it should have done in 1997 with the hidden epidemic. You know, and we're really trying to look at things that should be done now, like, you know, what in the realm of primary prevention, secondary prevention, and care. So there's no literature review, there's no innovation, there's no what whiz-bang things do we need to have a better understanding of to inform new interventions, innovation. Sorry to put all the pressure on you guys, but you know, to me, this is what the field needs, is to take a look at where we are today and where the nation needs to go, you know, and make a stamp on that. I think, you know, the HHS plan is for the federal government in the first iteration. I see these all as kind of sequential. I don't really know, Rose, when you're planning on having some document available, but we thought there'd be a little bit of a sequential approach, that this goal is, you know, on a fast track for the HHS plan, but I would say the scope is much narrower. It's also a different group of people. I mean, it's federal government people coming up with a plan. You guys are not, you know, the federal government. You have an opportunity to really make an impact on STIs like I don't feel like I've ever seen in my career. So that's, and then we've got the NAPA study as well, which is the public health administrators who've been looking at it more from the lens of an, you know, public health administrators who are usually health officers or things like that in state and local health departments. And they've got another plan that's coming out, I think, within the next month, which again was supposed to look at what state and locals were doing around STDs. And I think they'll be sharing some case examples and, you know, what they found. So I do see them very differently. If that's not being clear.
Oh, it's very clear. Thank you.
You know.
Appreciate it. And progress towards the future is our middle name. So Sean, Sean, no? Yes?
And this relates to that question and answer. There have been advances in modeling, data science, artificial intelligence advances, which are still exploratory but look toward the future. One way to progress on that and potentially make recommendations relies on data, on frequently updated data. With STIs, it's actually, their data are pretty good, weekly data. But are there, I think it would be really important to partner and be able to get access to frequent data. Are there initiatives in place for more timely release of data to be able to think about that in terms of recommendations?
So again, I'll answer, then I'll look to Gail Boland. One of the things, so I'm actually happy to hear you say that you think there is good data. And maybe it's just personality that I'm always, in all the things we do, I'm always looking at, we need better data, we need better data. But one of the things that we're doing in the STI Federal Action Plan is we can only measure by the data we have. But I think there are a lot of gaps, and we've asked our indicator subcommittee, and we're going to be asking our steering committee to talk about developmental indicators. What do people think we need to measure that we're not currently measuring? And are there time lags that need to be shortened? Well, I'm going to say, let me just see if,
Well, there'll be more data tomorrow when the surveillance report comes out. And also, I always say at CDC, we're sort of at the bottom of the food chain for data because everything has to, except for special studies, come up through local health departments, state health departments. But we're at the top of the food chain in terms of money. It takes us forever to get the money out. So we are trying to look at new ways that we can collect better impact data. We don't really have good impact data. We have a lot of process measures that we get through our grants. But they're all, we have a program grant, we have a surveillance grant, we've got a training center grant. So, I think that we could do better in the area of program impact, which also feeds into sort of the business case model. And I think we're not collecting a lot of, kind of data around a lot of the things we discussed today here. And how do you measure stigma and how do you, look at some of these social determinants of health? We've had a very limited sort of surveillance epidemiologic data systems. So I also agree with Carol. I think, we definitely feel that we could do better in the data arena, not only timeliness, but in terms of the types and variety. And as you know, the whole world's moving into data science, so we've got to figure out the velocity, volume, and variety of our data and keep up with that field as well.
Thanks for your comments. I have a question about alignment, but that'll require just a kind of a brief statement. And that is that many of us come from a time before there was any treatment for HIV, where the main intervention we deployed was the treatment of STDs, because we and many people had demonstrated that STDs were amplifying the transmission of HIV. As it turns out, the antiretroviral drugs overwhelm that aspect of HIV, and the PrEP agents that are available seem to be render STDs irrelevant in terms of acquisition biology. However, I've been really shocked that the plan, the 4 pillars of the End the AIDS plan, really don't address STDs at all or STIs at all. And that really has gotten my attention. I've had the privilege of hearing every federal official talk about the plan, which has been great. So I feel I could give the lecture. However, and with the pillars, but I'm just kind of shocked for alignment, and especially vis-a-vis this committee, that that isn't in the End the AIDS plan. I'll stop.
all right, so the synergy between HIV and STIs, HIV is an STI. It's not explicit in the plan, but it is in the plan. And in fiscal year 19, we used the Minority AIDS Initiative Fund to fund some initial efforts. And in doing that, we are leveraging the STI clinics to do the HIV, and we hope to do vice versa as well. So it's not explicit in there, and just like there's a number of states and local jurisdictions that have integrated HIV and Hep C. And I know Indian Health Service has done that as well. So that's not specifically in the plan, but it's happening.
So, but what if we came to think of this as the 5th pillar? How does that?
Integration?
Yeah, integration of the STI problem into the 4 pillars of the End the AIDS plan.
So the Ending the HIV Epidemic Initiative is a work in progress. It's initially a 5-year, then a 10-year plan. So we do think we modify things, we learn as we go. It's also a very community-based plan where every community is determining its own plan of how to do this. And so it'll be up to the communities to the extent that they do what you're suggesting. I think at this point, it's pretty unlikely that in terms of the promotion of the plan, that a 5th pillar will be added. But it's definitely in there, just not as a named
Provocative.
pillar.
That was meant to be provocative, but hopefully
That's
it wasn't.
okay.
Right, thank you very, very much.